Hi, everyone, and welcome to our weekly What's Up Doc series. We have a very special guest for our brand new What's Up Doc, Australia. We have our 2023 Global Vascular Doctor of the Year by the Global PAD Association. We have Dr. Shannon Thomas, who is here with us. We are so blessed to have you. I know you've been on and you've done a few Q&As with patients in the past, but this is special since you've been 2023 Global Vascular
Thank
Doctor of
you.
the Year. You know, if I could give it to you every single year, I would, you know.
Oh, thank you. You're very kind. Very kind.
So just tell everybody a little bit about you're a vascular surgeon, you're in Sydney. Tell us about your practice just so we can kick things off.
Yeah, so I'm a vascular surgeon here in Sydney, Australia, at the Prince of Wales Hospital, and I guess one of my areas of interest or real passion areas, I guess, is peripheral arterial disease. I self-interestedly, I think I come from a family that has diabetes and cardiovascular disease. So I've seen family members go through bypass surgeries and things. And I've really, when I was younger at least, saw the suffering, I guess, that goes after having your chest cracked open or having big wounds made on your leg. And so, yeah, I think I've had an interest in trying to develop and sort of bring to patients minimally invasive treatments that can achieve the same outcomes. And so, yeah, for me, vascular surgery was the way to do that. And in particular, I'm sort of aiming my career towards dealing with diabetes, the sort of effects that diabetes has on the vascular system. So I do kidney transplants, I make fistulas because of the kidney issues. I do a lot of limb salvage. And in particular, I did my fellowship with, maybe you guys know, Marco Manzi and Mariano Polena in Italy, who specialize in doing, sort of diabetic foot salvage and getting right into the foot and opening up all those blood vessels. So yeah, that's sort of a little bit of my background and interests.
But it's interesting that you've been a vascular surgeon there in Australia. Very few vascular surgeons are trained in these advanced tools and techniques. And yet you were able to figure out, hey, this is something that I want to do, even though I'm not seeing this around me. What was the catalyst for you to say, oh my gosh, this is what I want to be doing. I need to go to Italy. I need to meet with these pioneers, Dr. Mariano Polena and Dr. Marco Manze, who are at the forefront of even developing brand new tools and techniques to try and get clear into the smallest vessels in the feet to open those up and heal wounds.
Yeah, well, I think when I was a trainee vascular surgeon, so here in Australia, we travel all around Australia and New Zealand. And we would do a tibial angioplasty, and the people who taught me were like, don't put the wire into the foot. You don't want to injure any of the vessels there. And I remember just unfortunately seeing these patients in hospital for months on end with wounds that were indolent and not healing. And I used to think to myself, there must be some solution to this, like what is, how do we, why don't these wounds heal? Like, the teaching is inline flow to the ankle, but no one, at least 10 years ago, no one was really talking about the foot. And I was very lucky that I got to hear about, well, Marco Manzi, and then my colleagues here arranged like a scholarship for me to go over and learn these techniques. And so, yeah, when I went there, it was sort of like, it was amazing. It was amazing. And it totally changed my perspective on wounds, like 10, 11 years ago, before the angiosome concept was well known. And at that point, I realized that these guys were onto something, that it is about blood flow into the wound, not just into the vicinity of the foot. And it absolutely does improve outcomes, and it makes healing quicker and more definitive. And I believe you also save more of the foot as well, which is so important.
So what is the climate like over there in Australia? Is it like what it is here in the US or even in in England and oh gosh, okay, we're just going to say it all over the world, where you have this
Yeah.
contingency of doctors, maybe 10% of doctors that are like you, that are trying to exhaust all efforts to save the limb, even if it does mean a revolving door and consistent treatments, 1 or 2 times a year versus the 90% that are still out there saying it can't be done, it shouldn't be done. The patients are better off with an amputation. So patient go walk, walk, walk. And when you're in so much pain that you can't take it anymore, come on back and we'll just take it off.
Yeah. That's a good question. I think so. We've actually been looking at our government data, and
Yep.
for sure we are seeing amputation rates are not rising in Australia, but the number of peripheral interventions is going up. So I think we are seeing a mass adoption of endovascular treatment. And we are definitely saving more limbs in Australia. I think that's not probably universal, though. In Australia, we have this thing called a postcode lottery, and it's because the country is so big that, if you're in an area of Australia where they don't have a specialized limb salvage team, you're probably going to lose your leg. And so it's the tyranny of distance in Australia. We're not like the US where you've got big cities at very regular intervals. We've got a desert in the middle of the country, and a lot of people actually live in that area. And a lot of the people who live there are at risk of PAD and losing their limb. So in big cities like Sydney, the limb salvage rate is pretty good. We have multidisciplinary foot care teams. But then as you get further out away from the cities, that becomes a problem. And I think it's really incumbent on us to either go out there into the country areas or to develop the pathways so that patients know where to go for advanced limb salvage.
So I assume you have a standard set of protocols, for how to treat, these patients across, society guidelines or something that guides you to say, hey, you need to do X, Y, and Z prior to amputation, or is it still a little bit of the wild, wild west in some of those more desert regions?
It is. It is a bit of the wild, wild west. I mean, there are I think frequently patients aren't even referred. Maybe they're referred to the local general surgeon or the local orthopedic surgeon who just removes the leg or attempts to remove some of the toes and then the leg goes. So, yeah, I think that's one aspect to it. We've got a lot of new younger surgeons who are coming online now. So I think we are beginning to see a shift towards more endovascular focused practice rather than this sort of debate about open surgery. So I think that's changing as well, but it's taking time. Yeah.
It's there's nothing against open surgery. I would even rather, and I even guide patients, and it's helpful for me to know if there are certain areas where, the patients know that, at the very least, hey, doctor, you should be doing a bypass. Hey, doctor, you should be doing an endarterectomy. Refer me to another doctor. If you're just saying you're going to cut off my leg, then at the very least, if you don't have a doctor there that performs endovascular options, at least we can kick the can down further and give them, another 5 to 10 years possibly before they need something else. And maybe by that point, there will be newer approaches, newer tools, newer techniques in your region or their region that are adopted, right?
Yeah, absolutely. Absolutely agree. Yep.
So they should at least be asking and saying, hey, don't just cut off my leg. Well, do you have some sort of bypass option? Is there some sort of endarterectomy that you can do if you don't do endovascular? But there is a lot of issue between public and private hospitals, just that, is there, well, we don't have public private, but we have government insurance, and then we have, of
Yeah.
course, private insurance. So a little bit, of the same. How does that work there in terms of patients if they're in the public hospital and they come to us and they say, they just want to cut off my leg? What
Yeah.
How can we get them to private? How does that work to get them the referrals so that they don't get alienated or piss someone off?
Yeah. Look, so in Australia, we have universal healthcare. So as an Australian citizen, you get free healthcare. And I think we're all quite proud of our universal healthcare system here in that it is very high quality. So the private system really allows you to jump the queue. So, in the NHS where it's only public, there's a massive queue and you can't get ahead in any way. Whereas here in Australia, the private allows us, if you pay a little bit of, or it's quite a bit of money these days, but if you pay some money into your private healthcare fund, when you need to use it, you go to the top of the line and you get your treatment done straight away. Look, I think when in my practice at least, I'd say the majority of patients with PAD are publicly insured. I don't treat them any different, whether they're public or private. For me, it's PAD. It's a patient. They need their leg saved. That's it, right? And I think if someone, even in a public hospital, is being told that they need their leg removed, they have the right to seek a second opinion. And they can really go anywhere in Australia. The burden really is on them at that point if they discharge themselves from that health facility. But I mean, we get patients all the time here at Prince of Wales coming to us from other hospitals where they've been told that they need their leg removed, and we do some procedures and save them. So yeah, it's certainly not unheard of. Yeah.
It was interesting a couple of years ago when we first met, you were talking about how frustrating it was that Australia always seems to be the last place that gets all the new innovation. But I was really excited to see a paper that was put out by a couple of your colleagues talking about the drug eluting reabsorbable scaffold. I believe that
Mm,
you're talking about the one from Abbott, the Aspiri, versus
yeah.
angioplasty for infrapopliteal arterial disease. And that blew my mind. I thought, oh my gosh, they're on the cutting edge of something right now.
Yeah, so my colleague actually in practice here in the rooms, Ramon Varka, that's his baby, and we actually did the original what was it called, the original BVS, the bioresorbable vascular scaffold. The name escapes me, but the first version that came out from Abbott, we actually did a trial here at Prince of Wales, where the three of us surgeons were enrolling patients, and it was amazing. In BTK, I mean, we've still got patients who are coming back, and you do a run and you can see the little two markers where the BVS was, and it's patent and it's healed and it looks beautiful. And that really spurred Abbott to invest in that big RCT that you've probably all heard about recently. And the results are fantastic, and they truly are in terms of patency. You implant one of these things, and when you go back and have a look, it looks like it's healed. It looks like a normal vessel. It's crazy how it works. Yeah.
And I do you think that that will help be a catalyst for driving more doctors across Australia to possibly do more to treat below the knee? Because so many were concerned. I mean, just even here, even in England, because of that revolving door of treatments we always talk about. And this supposedly could least delay that revolving door.
I hope so, Kim. I really do. I think, I mean, I'll be honest with you. My personal take on the revolving door is it's not such a bad thing. We have this thing over here where you become a victim of your own success, right? Like the reason that patient's coming back to you is because they've still got their leg. Their PAD hasn't vanished. It's not like they're suddenly cured of PAD. They've still got PAD and they've still got a leg. So of course they're going to come back to you, right? That's a good thing. And the only thing that we caution is the frequency by which they come back to you. So if they're coming back, every 3 months, that's not reasonable. But if, I have patients who are coming back for procedures every 9 months to a year. but they're enjoying their life. You know, they've got their leg. Um, they're working on their PAD. You know, they're not smoking. They're trying to do the walking every day. They're doing all the right things, but their PAD hasn't vanished. And so,
No.
of course, things are going to reach the nose. And that doesn't mean that we give up and just throw in the towel and chop off their leg. It means that we do a very minor, you know, sort of day-stay procedure to open up the arteries and let them back and enjoy their life. So I don't think recurrent procedures is necessarily a bad thing.
No, and people, we've had quite a number of people that are even here on in our live studio audience right now that will tell you that they don't care how many times they have to come back if they can just like chemo or radiation gives a cancer patient just one more day to love and hug on their family and their children and their grandchildren. It's the same with a PAD patient. A PAD being a disease that's more prevalent and deadlier than most cancers combined, except
Yeah,
for lung
yeah,
cancer. And yet they don't get the same courtesy in so many situations. They just want to be able to keep their legs, which means they can actually keep their life for one more day or another day or another day or another month. And I think that that's so important.
yeah.
It is so nice to see that you're doing that. And hopefully, I'd love to hear about your efforts to spread awareness and to create that diaspora that we want to see across Australia to hopefully get more and more doctors to adopt these new methods, and even getting industry to get in there and support the new techniques and bringing in new tools into the country.
Yeah, I think something that's probably very important is where a patient, I think this is what it's boiled down to. I've thought about this a lot. I think a patient needs to feel heard. Like when they go and they see the doctor, they need to feel like, yes, they understand I want to keep my leg, or they understand I'm sick of having had all these procedures. Whatever it is, they need to feel heard, and they need to feel like the doctor is going to do everything they can to achieve that outcome. So, like I've met the rare patient who say to me, "Oh, look, I've been with this other doctor. I've had these many procedures. I'm sick of it. What can you do to stop me having procedures?" And that's a very different conversation to someone who's saying to me, "Hey, this doctor has said they're going to chop off my leg. Please just keep the leg attached to me." And I think most there are some doctors who won't listen. They won't. And they'll just do whatever they'll look down their nose at patients, and they'll do whatever the hell they think is right to achieve an outcome that the patient doesn't necessarily want. And I think that's where amputations and all these things come into it, where patients feel they're getting a solution that they didn't actually want or ask for. I think that's the most important thing. And in Australia, we all have the ability to choose. So I think if a patient sees a doctor and feels that that what they want isn't being enacted, they should go somewhere else.
Is there a policy? Is there a protocol? Do you have a certain place that patients can go to within facilities to make sure to not necessarily file a complaint, but if they can't, if their primary care says, "Hey, I'm only sending you to this doctor. The referral's only going there. I'm not sending you anywhere else." What do they have to do? Is there any way that they can have that choice to go somewhere else in a public system like that?
Yeah, so that's probably, we don't do this part very well. You do have the right to a second opinion, but a lot of patients, I mean, in Australia, I don't think our patients are as empowered as the US, where, there's advertising and, people are, it's front and center that you can go get a second opinion. I think in Australia, a lot of patients still kind of look at the doctor and say, well, he said whatever, that's what's going to happen. But it's very simple. I mean, you can just, if you're a patient and you're not happy, you just Google it, and a whole bunch of other doctors in the area will come up, and you can use that then to find a doctor for a second opinion. You don't even need a referral from the GP, technically speaking. You can just go and see them. Yeah, the referral is so that Medicare will pay for the consult, but you can pay yourself for the consult with the doctor and then get the referral later on. So yeah, but we don't do it very well. But yeah, certainly you can get a second opinion if your GP is not referring you or has referred you to someone that you don't like. Get a second opinion. There is certainly no harm. I have patients of my own who go and get a second opinion, and it's great because they'll then at least they're getting heard. If I haven't heard them correctly, maybe someone else will. Yeah.
And we have a couple questions coming in. I'm going to get to you one by one. So just make sure when I call on you, just go ahead and unmute and ask your question. We're going to start with Douglas. Go ahead, Douglas, unmute and ask Dr. Shannon Thomas your question.
Well, yeah, I think you just kind of basically, I was wondering about the patients. Is their knowledge different there than it is here? And here, what we're going through is a lot of doctors and patients are coming together to learn. Because I didn't know about PAD till 2 years in my process, a little over 2 years, and we have people that aren't diagnosed until we get with groups like Kim's and we become more knowledgeable. So and I think you kind of were answering that about the patients there compared to here.
Yeah. No, we look, we don't have that. We don't, like I said, I think in the US, patients are a lot more empowered to choose. I think in Australia, look, we do try and educate patients over here, but it's not as well developed as it is over there. And I mean, I wish Kim would spend more time in Australia. We're focusing on the Australian population.
I would love to get on a plane and come your way. That would be really fun. We should plan that for 2025. Say, hey, Mark,
Yeah.
Mariana, let's do Click in Australia next year. That would be so much fun. But we are going to try and do as much as we can. We'd love to get some awareness campaigns out there. We do have a couple dozen people that are in our network that are all in Australia, including a couple that we're going to get to right now with their questions. But we can all just get together and let's see if we can strategize to find ways in which we can start slowly but surely creating some awareness campaigns. At least to get people, start with getting people tested. I think that would be really, really helpful. But we have, let's see, Kevin. Kevin, go ahead and unmute and ask Dr. Shannon Thomas your question.
Hello, Kevin from South Australia here. Just wondering why we can't get cilostazol in Australia.
Yeah, Kevin, that's a good question.
In our group.
I can hear the accent. Yeah. Big problem, Kevin. It's a big problem. I had I had 5 or 6 patients on cilostazol when it was pulled. I actually spoke to the company. It's a Japanese maker from memory. And so basically Australia was not panning out to be a lucrative market for them. And so they pulled out. So that's why we can't get Plital over here. Yeah.
I think that's so sad because it's something that is really helpful. I read a study that said that it was only helpful in 30% of patients, but when it worked, it really worked. And so it was always worth trying. If it didn't work, the side effects were no fun. So just cut it off. But to hear that because it's not a lucrative market for the company, that they would pull it is really sad to me because it's interesting. I go to some of these conferences and I talk to different people in industry and even the pharmaceutical companies here. And the people are so passionate. The ones that are at these events that I talk to are so engaged. They have personal stories that drive them to do what they do within the industry. And it just blows my mind to hear a story like this. And here's Kevin that's like, gosh, I want to walk further. I want to avoid procedures. I know this drug will help me, but because there's not enough people here and money here, we can't get the help we need. And that's frustrating. I mean, I can imagine it's frustrating to you too. I can hear it in your voice.
Yeah. There is an alternative that is available here called pentoxifylline. but it's not as good. I don't believe it's as effective as cilostazol. So yeah, it was a real loss when they pulled it from the market. Mm.
Well, maybe they can make enough elsewhere that they can that would subsidize bringing it to Australia. You can only
Yeah.
hope, right? Or maybe there will be someone that will come up with an alternative, for patients and democratize access,
Yeah.
to another alternative. Angela, go ahead and unmute and ask Dr. Shannon Thomas your question.
Hi, Dr. Thomas. Thank you for joining us. It's really great to be part of this Zoom meeting today and hear that there's someone in Australia doing some really good stuff. I'm from Adelaide. I have some complex issues with calcifying arteries. I was first diagnosed with CAD about 5 or 6 years ago. But I've since found that it's all over the place, particularly through carotid arteries. My subclavian steel's quite blocked. I have a lot of problems with my arms. And I've also recently been having a lot of TIAs. So I've been waiting months to get into the public system. I've seen another doctor a number of times about my legs and particularly my feet. They have had small ulcers, but, I do a lot of walking and I try really hard to live well to try and keep this, slow this stuff down. But there was, I talked about having, unblocking the lower part of my leg a couple of times. And it's like, oh, we're going to do a revolving door thing. You're too young. I was in my 50s. You're too young for all of that stuff. No one really seems to be that interested. I've been to see private a few times with the same results. I've been to the public system with the same results. So basically, I'm wondering if you know of a particular surgery in in Adelaide where doctors do interventional stuff. They all seem to be connected to each other anyway. So if you ask about one, that how it's all in the hospital system, they've got all your notes and every doctor can read everything. So they just like, I've actually felt like I'm hitting my head against a brick wall trying to get some help with mine, particularly since the subclavian's even more blocked and, my arms are getting weak and now I'm having, frequent TIAs, which is causing some damage to my brain. So anyway, I'm just sort of feeling at a loss. I don't really know where to go in South Australia for that.
I'm very sorry to hear that. Look, I think for some reason we've had a few patients from South Australia. I don't know what's going on there. I guess maybe offline we can talk about who you've seen and maybe getting you to see someone a little bit more reasonable out there. But geez, if you've got ulcers on your feet, that's a definite indication for treatment. Particularly if you've got occlusions in your arteries. I don't quite understand why that would be managed conservatively. The subclavian, if you're getting pain and you're getting TIAs, then I'm not sure why that's being managed conservatively either. So
it's terrible because I had an MRI about 4 months ago, and I still haven't been seen by anyone, even though the MRI showed getting flustered. It showed that there had been strokes. They weren't acute. They were subacute at the time. And it's in clusters. And there's damage to the cerebellum in my brain as a result of these strokes. And I'm on a wait list to see a doctor. And this was end of April this year. And I'm still waiting. And, my memory's going as a result of this, which happens when you have TIA. So I have a mother who had vascular dementia.
Yeah.
I'm nearly 62 now. I first found the pad when I was 55 with a 100% 13 centimeter occlusion in my left femoral artery. I had no treatment whatsoever. I walked and walked and walked because I joined this group as soon as I could, found out about walking, built collaterals in my leg only to find that they're in through my torso, parts of my body. I've got blockages all over the place. I had a heart attack when I was 52, and that started this, and there was no heart disease. I don't have heart disease. I had a clot lodge in my heart with absolutely no atherosclerosis in my heart. And it was baffling to my cardiologist that I would have one at 52. I was a dancer and I was really fit and I had a very healthy lifestyle. And there I am at 52 with a heart attack. And I have a family history of this. My father died at 54 from a massive blood clot in his leg that went gangrenous, and he died of sepsis. And that was at the end of heart attacks and strokes. So I have a huge family history, and still it gets ignored. And as soon as anyone finds out, that any of the doctors find out that in my earlier life I was a smoker, don't want to know. And it's all put down to that. And yeah, I have a huge family history and no one will see me. So I do feel a little frustrated with all of this. And I have a good GP, and I do have a good cardiologist, but they still refer me to the same place and the same vascular doctors who have no interest in treatment. So I feel like I'm just, hitting my head against a brick wall.
Yeah.
Anyway, thank you for letting me rant. I really appreciate that.
It's important, that you have a place, Angela, that you feel like you're heard, that someone's hearing you, and we are hearing you. And it is disconcerting to see that, but it's interesting here, even in the States, in some areas, we have the same problem, that we do have some community hospitals where there is a vascular team that has their way of doing it. They've been doing it together for 30, 40 years. They are 9 to 5. They don't want anything beyond that. And I even had a doctor, Dr. Thomas, you're going to love this. I had a doctor just on Friday say to me that, well, we could potentially treat the feet, but we just don't have time. So we just send them to go get them cut off.
Oh, jeez. That's terrible.
But the fact that the stuff people tell me, like, why are you actually saying this? I couldn't believe it, but this is real, and you as a patient need to know that this is real, but you have a right, you can fight, and we just got to figure out a way around it. And Angela, we can take it offline, and I'm sure that I can see Dr. Thomas already has some ideas, and I know he's helped me with a couple people already in Adelaide. So if we can work with you to figure out a way around this, as he was saying earlier on, that you do have a right to a second opinion. Most people don't know it. If you can't get through with your GP, then maybe you can just go ahead and pay for at least the consult, and then get the government coverage to cover any sort of procedure that's necessary after that. Get the referral later. And if you do need help covering a copay or something, or that original consult, and that's deterring you from doing that, go ahead and message me, because the Global PAD Association will help you to cover that. Okay.
Thank you.
I think, Angela, also you can send me your maybe offline we'll have a chat and we'll work out who you've seen, and I can actually contact someone there in South Australia about you and get them to see you and sort you out.
Yeah.
Thank you.
See, that's why we love Dr. Thomas. We appreciate you so much. So as we come to a close, we know we only have about 10 more minutes with you here, but I want to talk to you about what you're looking forward to most in the next year in terms of innovation and new tools, new techniques that are coming to the forefront that you think are going to impact patient outcomes in Australia.
One of the things that I've been really interested in Australia at the moment, we're getting a lot of thrombectomy devices becoming available. So essentially what these devices are, if you get a clot in your artery, these instead of ballooning it, or instead of doing an open cut and trying to remove the clot, these are catheter systems that you can put next to the clot. you turn on a button and it sucks the clot out, or it macerates the clot and removes it. And it, I think this is going to be a big game changer for limb salvage, because I know for a fact that a lot of my colleagues, when a stent blocks, in their mind, that's it. Oh, the stent's blocked. I either have to do a bypass or chop off the leg. But these devices allow you to go into that stent and remove all of the material that's in that stent or in that artery, and it looks like brand new once it's all come out. And actually, I should preface this by saying we've been doing these procedures here for a while, but it's only now this year, 2024, that the companies are really competing with each other to get their devices into more hands in the Australian market. And I think one of the reasons is Abbott are really pushing their Jedi system, and now suddenly the other pre-existing guys are saying, oh, geez, we better invest more as well. So I'm hoping that that is going to really allow a higher rate of salvage of occluded stents and occluded arteries where previously people were giving up. So that's what I'm excited about in Australia for the next 12 months.
And are you dealing with just DVTs, but are you getting those devices such as with Inari, and there are a couple other ones that have them for the pulmonary embolisms as well?
Yeah, so you can obviously remove clot from the venous circulation. So we've got Inari to mention, we've got Jedi as well. And, I had a patient, I think it was about 4 weeks, not that long ago, who had a very, very bad DVT. And the traditional treatment is you make a cut in the groin and you pull out all of this clot, and then they sit there on the ward for, 2 to 3 weeks with the wound breaking down. And anyway, I used the Jedi catheter system for the vein clot, and she was home the next day. It was fantastic. It's such a big change for DVTs. However, the main thing I'm really excited about is on the arterial side, because it's way more common that we get blocked arteries over here. And yeah, I think these devices, so you've got AngioJet, you've got the Jedi system, the Rotarex system, and they're really impacting the way that we practice. I've seen, I've been doing Rotarex at least for a couple of years now. I've seen patients where every single artery in their leg is gone, is blocked. And you do Rotarex, you pull out the femoropopliteal clot, you do an outflow angioplasty, and everything looks beautiful. And they're back out, they're back to the community, back to their life. And sure, they come back in, 9 months, 12 months, everything's blocked again. You do the procedure again, and back they go. And these procedures, you do it, you can send them home the next day. I mean, it really gives patients, it's not perfect because they have to come back, but still, it means that they've got their independence. They don't have to go to a nursing home, et cetera, et cetera, et cetera. There are just so many benefits, I feel, to these devices. Yeah.
I mean, it's especially beneficial to the patients, but then to the entire healthcare system, and above and beyond that, as Dr. Marco Manzi from Italy, one of the pioneers in endovascular, always says, socially, the impact socially of helping people to maintain their independence is priceless. Why wouldn't you do everything in your power to help improve not only the patient's life and the impact on the patient's life, but that on society, right? And remove those unnecessary burdens.
Agree 100%. Absolutely correct. Yes.
And in terms of the patients, we always get asked a lot about the medications. What are the protocols for medications, for the disbursement of medications for someone, who is diagnosed with PAD? Here, you're told you, depending on their situation, aspirin and a statin, maybe a blood pressure drug. And then, after a procedure, they might get, let's say, Plavix or Brilinta and or Xarelto or Eliquis. What's the protocol there?
Yeah, so that's true. So most patients, when they're diagnosed with PAD, will be started on a statin and aggressive blood pressure control. risk factor modification. So we get them to stop smoking, make sure their diabetes is being properly managed if they've got that as well. If they have a procedure, then generally I'll put them on clopidogrel and aspirin, dual antiplatelets for maybe 3 months, depending on exactly what lesion we're treating. If it's a recurrent problem, particularly if there's a thrombosis that's occurred, like a clot has happened, I might put them on a DOAC, so Eliquis or Xarelto, instead of the clopidogrel or instead of the aspirin. We also have a small subset of patients where if they've got PAD and they've got severe coronary disease, and I think they have to have diabetes as well from memory, they will actually qualify for Xarelto, low dose Xarelto treatment. So that's coming off the back of the Compass PAD results. I have a few patients where we've got them on long-term low dose Xarelto. The caveat in Australia is that has to be a multidisciplinary decision. So unfortunately, they need a vascular surgeon and their cardiologist and their GP all agreeing that that should be the treatment for them. So it's not as straightforward as just giving a script for clopidogrel or aspirin or even a statin. It is a bit more complicated, but I think we'll find that those barriers will come down in time for low dose DOAC. Yeah.
What are the protocols for getting a PAD patient's heart checked? Is it typical that the GP refers to the cardiologist and the cardiologist to the vascular surgeon, or does it go straight to, if they get diagnosed with PAD first, it goes to the vascular surgeon, and then how do they get to the cardiologist, or do they, for the most part, get to the cardiologist just for preventative measures?
Well, the good GPs will send them to the cardiologist at the same time that they send them to the vascular surgeon. And I've got quite a good group of GPs, certainly in my country practice where I work, who will do that because they know, I tell them all the time, once you've got PAD, you've got to make sure the coronary disease is sorted first. But I also do see a lot of patients who are referred with fairly late PAD, where, if they've got tissue loss, they can't wait. And so I'll take them in, I'll fix up their peripheral arterial disease, and at the same time, get a cardiologist to come and see them. Sometimes as an inpatient, or sometimes after I've done their PAD, I'll get them out. It's literally just down the corridor. So we'll get them out to have a stress test, or a nuclear scan and an echo, and go from there. But certainly it's in addition, I should say, we also will work up their PAD, right? So we don't just say, oh, okay, it's in your left leg. We'll do ultrasound scans, clinical assessments of the right leg, the carotids, the renals, the aorta, basically looking for all the places where they could have PAD and making sure it's sorted.
Oh, wow. So you do a full comprehensive approach, because that's not necessarily similar, in my experience in other areas. Sometimes they'll just do, you have pain in your legs, they'll do it, and they suspect that maybe it's in the thigh or down. They'll do it from the abdomen down. They won't go any higher. They won't check the renals. They won't check the inferior mesenterics. They won't check the subclavians. They won't check the carotids. Like, you have to push, you have to advocate to get these tests done. I mean, to even get a CT angiogram sometimes is a huge fight. And so it's nice to hear from your perspective that you're like, okay, we're going to do everything, at least get some sort of foundational look at whatever you got going on, things we might not even see yet, so we can get ahead of it, right?
Absolutely. So we all have vascular labs attached generally. You'll have a vascular lab attached to your clinical practice. So when I see a new patient with PAD, I want to know everything that I'm dealing with. So we get everything scanned. And if someone's got severe carotid disease, it's a marker of a higher risk for coronary disease. So you know, it puts it into that patient's medical story, that the severity of PAD and therefore the risk. And so it might just tell the cardiologist, hey, even though that stress test is normal, maybe you should do a CTCA, or maybe you should do a coronary angio, because they've got fairly extensive PAD. So yeah, absolutely. Look, I know my colleagues here do, but at other places, if patients aren't getting that full workup, they need to. Absolutely.
For it. It's interesting because Bambi, who's watching on YouTube, we're streaming online across YouTube at youtube.com/The Way to My Heart, and then across our Facebook channels as well. And she's saying that, oh my gosh, I didn't know you. I mean, you could have the plaque buildup elsewhere. Yeah, you can have it right in your subclavian. You can have it in your gut. You can have it in your neck. So it's the human superhighway, right? I mean,
Yeah.
if you have plaque one place, it's likely you have it in another, right?
Absolutely, absolutely. And I think it's very important to detect it, to be aware what's there, so that it can be managed. Yeah, I think, I mean, if patients are seeing their vascular specialist and that's not happening, then they need to demand it. Yeah.
And so one more question for you, doctor, and this is a little bit of a loaded question, and I know that different doctors have different ways in which they decide that they're going to treat or not treat. But what are your indications for deciding that you are going to do an intervention or a bypass? Is it, I mean, does it vary? Because you have people that are asymptomatic, and asymptomatic could mean even just like numbness, right? They're like, oh, I don't feel the traditional intermittent claudication. Then you have the intermittent claudicants. Then you have the lifestyle limiting claudication. And then ultimately, then you have the rest pain and the wounds that won't heal. And there are doctors that say, I am not going to treat until I see that wound, until your toe is gangrenous, we're not going to touch it.
Yeah. Okay. So I guess, first of all, there has to be a lot that should be said about non-surgical conservative treatment. If someone is asymptomatic, then absolutely we talk about stopping smoking, we talk about dietary modification, we talk about exercise, we talk about counting steps per day. I know, Kim, you've got that great little booklet that I've got here somewhere that I've been giving out to patients that explains to them, why do you have PAD and what are you going to do to stop it from getting worse? And the cookbook as well. So they're things that we give out. If someone, so generally speaking, if someone has claudication and it only occurs once a week, and it maybe only occurs if they're walking more than 100 meters, I will try to manage that conservatively, and not forever, but we'll try to manage it conservatively. So, I'll say to the patient, all right, let's get a pedometer, maybe like a Fitbit. Let's see how many steps you're doing per day. Maybe instead of watching TV for 3 hours, why don't you go for a walk around the block, or wake up in the morning, go for a walk, really try and manage things without intervention. Once we get to under 100 meters, I generally will find patients will tell me, I can't do anything without getting pain, right? So I go to the supermarket, I have to stop in the aisle because that's 100 meters. Or, I get to the lift and then I have to stop there and rest. And it really becomes lifestyle limiting. Now, when someone's lifestyle is limited by pain and there is an easy target for treatment, I will treat it. I will obviously warn patients that there can be this sort of revolving door, but the way to stop going through that revolving door is not to smoke and is to walk a shitload. Excuse my French, but really, really to walk after having your intervention done, because you've got to build the collaterals. You've got to push a lot of shear stress through that stent to keep it open, or wherever you've ballooned it, or done your atherectomy, whatever the treatment is. You want it to heal, you want it to positively remodel, and exercise is a really good way for that to happen. And of course, once someone's got CLI, critical limb ischemia, there is no role for conservative treatment. I think that is a limb-threatening and life-threatening situation. And so they will generally need revascularization of the limb, number one. They will need very advanced care of their medical comorbidities. So, referral to an endocrinologist, cardiologist, et cetera, antiplatelet treatment. And really, I worry a lot about CLI patients because a lot of them don't make it to the 12-month period after I first meet them. So, I don't see that there's very few that I manage conservatively in that group. Yeah.
Thank you so much, Dr. Shannon Thomas with Prince of Wales in Sydney, Australia. We really appreciate your time. And make sure, don't pop off just yet, but we're going to go ahead and close our stream and thank everyone for joining us. Of course, every Tuesday we do have our What's Up Doc. It is What's Up Doc Tuesday in Australia. I'm in the US. It's Monday, but it is our What's Up Doc Tuesday for the week. Make sure to join us next week. We do have a doctor that is going to be joining us to talk about the 2024 peripheral artery disease guidelines that were just laid out by the American College of Cardiology and the American Heart Association and agreed upon by all of the different societies. So we're going to have that next Tuesday. So make sure you don't miss that. I hope everyone has a great week.